Hello, everyone. Thank you for joining us for today's webinar. My name is Mary Corey, Education Specialist for WorldLink Medical, and I will be moderating today's event. I would like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser in the lower right-hand corner of your screen. You should see the chat box where you can enter your questions to Dr. Rouzier. They will be answered at the end of the presentation as time allows. Thank you for joining us for Part 5 of Testosterone Therapy. This web conference is brought to you by WorldLink Medical. We provide evidence-based, CME accredited education in preventive medicine and age management with a focus in bioidentical hormones. Don't miss our next course, Hormones and Beyond for 21st Century Wellness Medicine, scheduled October 6th through the 8th at the Lead Lodge in Omaha, an all-inclusive resort. It's all new content, so if you're waiting for new material from Neal, here's your opportunity. He will be sharing his tips and secrets for evaluating research studies and new clinical literature, and featured speaker Dr. Gerard Mullen will discuss obesity and the impact of the gut microbiome on this epidemic, plus treatment for irritable bowel syndrome and inflammatory bowel disease, plus so much more. Don't miss this opportunity to learn about current preventive medicine issues and enjoy this beautiful resort owned by the Arbor Day Foundation. Early registration discount rates are expiring August 4th, so register very soon. For those that are certified, it's a great way to fulfill the requirement of attending at least one course per year. Today's event is sponsored by an educational grant from MedQuest Pharmacy. We are grateful for their continued support in organizing the importance of patient and prescriber education in the field of bioidentical hormone replacement therapy. They are true leaders in the industry, and we are proud to be supported by them. Dr. Neal Rouzier is a pioneer and recognized leader in the bioidentical hormone replacement field, treating more than 3,000 patients almost since its inception in the early 1990s. With over 17 years of experience as an educator and practicing physician and 29 years of emergency medicine experience. Please welcome Dr. Neal Rouzier for today's webinar from his hometown in Palm Springs, California. Hello, Neal.
Hi, Mary. Thank you very much. Hello, everyone. I'm sitting here with my knee elevated as I just had a knee replacement. That was fun. Yes, it does hurt, but yes, I'm doing fine, thank you. Anyway, the impetus for today's lecture was twofold. Number one, there was a prominent physician, a bioidentical hormone expert, that was taking testosterone, obviously, and unfortunately developed a severe heart attack and died. And of course, everyone says, "Oh my God, it was the testosterone." And it's funny how the brain plays that game with people. And because of that, I organized a couple articles that criticized the idea or thought process that testosterone would cause the heart attack. It did not, but everyone wants to blame, oh, it's the testosterone on that. That's the first impetus for this lecture. The second one was for an article that recently was published in JCEM concerning normal ranges of testosterone. And it seems like every morning I wake up, there's more pushback against the use of testosterone, and this article was as such. I have recently spoken with the pathologists at Quest and LabCorp, and they, because of this one article written by 4 people, have decided to change the ranges of testosterone. They've lowered the total testosterone from 1,100 to 900 to be normal. And if you're above 900, then you're considered, abnormal. But it's interesting that, and I'm going to quote from this article, well-defined reference ranges are at the heart of clinical practice, and without them, clinicians can make erroneous diagnoses. In other words, if the person's level of testosterone is not low, that he could have an erroneous diagnosis based on the fact that he didn't qualify, that could lead patients to receiving costly lifelong treatments that they simply don't need. I can't believe that they actually came out and said that. So the impetus for this paper was to create more restrictions or guidelines which restrict us from using testosterone or using the doses that we would normally use. And as many of you know that have taken the courses, you know, if you don't get your level up high enough, you're not going to see a change in parameters. And I'm going to go through those articles that show those changes in parameters. And typically it's with much higher dose of testosterone, which is now being sort of restricted based on four authors, this one paper that everyone sort of jumps on the bandwagon and uses to criticize or restrict further our use of testosterone. So that's the impetus for today's discussion, things that I think everyone should be aware of and have the medical literature and data to support why we do what we do. So starting off with this unfortunate physician that had a massive MI, a widowmaker, and died, this article here from Vascular Health and Risk Management looks at testosterone and cardiovascular disease from a long-term perspective. In this study, we investigate the effects of long-term testosterone up to 8 years. The gold standard would be 10 years. This one, 8 years, in men with a history of cardiovascular disease. So what they looked at was not normal men. They looked at men that had already pre-established heart disease. So it was sort of a secondary study. Let's pick men that already have heart disease, give them testosterone, and see if their outcomes are worse. It's really nice to have all these observational studies, observing that low levels are harmful and high levels are more protective, but we really need to see and understand and know and realize what happens when we intervene and do an interventional study. So this was sort of that interventional study, but not quite. In 77 hypogonadal men with a history of cardiovascular disease who received testosterone, we observed a significant weight loss and a decrease in waist circumference and BMI. We certainly don't want to see any increase in risk factors, and in this study we saw a decrease in almost all cardiovascular risk factors. The mean weight decreased from 114 kilograms to 91 kilograms. Holy smokes. That's, 23 kilogram in weight loss. That's over 40 pounds. That's a significant weight loss, a significant benefit that the cardiovascular world just simply ignores. Statins do not make you lose weight, they make you gain weight. They raise your blood sugar, and in many such situations and circumstances can actually lower HDL. In this study here, we saw an improvement in lipids, an improvement in glycemic control, a decrease in blood pressure, a decrease in heart rate, a decrease in pulse pressure, all improved significantly and sustainably all the way through the entire article. No patient suffered a major cardiovascular event during the full observation time of the study. So even in patients that had bad disease, they already had pre-established heart disease, a secondary study, they were given testosterone, they found no increase in events. In fact, they found the opposite. Conclusion, testosterone therapy appears to be effective in achieving sustained improvements in all cardiometabolic risk factors and may be effective as an add-on measure in a secondary prevention of cardiovascular events in hypogonadal men with a history of heart disease. As an add-on, the cardiovascular world right now is completely against the use of testosterone. They think, oh no, it causes heart disease. Oh no, these studies showed. And it's just absolutely amazing the amount of data and studies and material that we simply ignore because of one or two flawed studies that showed potential harm, and we ignore these studies that show tremendous benefit. So in my mind, no, you don't want to cause harm. And I think many of the pundits that push back against the use of testosterone use that as their claim, we don't want to cause any harm. But on the other hand, I look at the other side of the coin of what harm are you causing by not using it? What harm are you allowing to occur if you don't use the testosterone to protect against heart disease? And this is exactly that type of study. There was an extremely well done study to show that you really need to use it as a secondary add-on measure in addition to what you use for primary disease. The scientific evidence suggests that testosterone deficiency increases the likelihood and degree of coronary atherosclerosis. Every study shows the same thing. Low levels increase the risk, high levels are protective. Hypogonadism, however you define that, is associated with increased cardiometabolic risk. I define that as levels on the lower 50% of normal, normal meaning average, and an increased risk of all-cause and cardiovascular mortality. So if every study shows low levels are harmful and high levels are protective, where would you like your levels to be? Well, I want mine to be optimal, where it's protective, not on the low end of the range. While higher levels were associated with lower incidence of sudden cardiac arrest also. So there's less plaque buildup, and there's certainly less plaque rupture, or MI. Despite the wealth of knowledge in the field of testosterone therapy and cardiovascular health, a few studies have recently reported controversial outcomes. I have listed 4 or 5 articles here that discuss those controversial outcomes, so it will be somewhat redundant. But hopefully in this redundancy, it shows that these articles should really be ignored. But yet everyone wants to hang their hat on these controversial studies. However, in response to a petition to place a black box warning on testosterone products, both the U.S. Food and Drug Administration and the European Medicines Agency have evaluated the available evidence and concluded that there's no credible evidence, in other words, these studies are flawed, that testosterone therapy contributes to increased cardiovascular disease risk. And, of course, all the other studies that are not flawed show benefit, but yet somehow these studies seem to be ignored. More recent medium-term studies have refuted such claims, and that's, again, the impetus of this discussion. Conclusion. Long-term testosterone therapy in men with a history of cardiovascular disease appears to be an effective approach to achieve sustained improvements in anthropometric, that's visceral fat, and cardiometabolic function with no reported increase in cardiovascular events. And that's the key is, well, yeah, we can decrease the risk factors, but we want to know what the outcomes are going to be. That recent study in JAMA showing an increase in plaque. That was soft plaque, not hard plaque. But yeah, we still want to know what the outcome, but everyone wants to hang their hat on that study showing that there's an increase in soft plaque, but all the subsequent studies show a decrease in events. But everyone ignores the decrease in events and wants to hang their head on, yes, there's increased plaque, and it's soft plaque. The fact that none of these high-risk patients had another cardiovascular event may suggest that testosterone therapy can have a beneficial effect in men with a history of cardiovascular disease. Why would you withhold a therapy that has been shown to be so protective and so beneficial based on the fact that a few flawed studies sort of taints your opinion? That's really too bad. Epidemiologic and observational studies have shown that low testosterone is associated with increased risk. A meta-analysis of 70 studies indicated that patients with cardiovascular disease demonstrated significantly lower testosterone and higher 17-beta estradiol levels, which remained significant markers. I won't address it much in this paper, but as you go through it and analyze this paper, everyone understands the low testosterone, but not everyone understands the high 17-beta estradiol level. And of course, the 17-beta estradiol level was elevated all in patients that were obese and had diabetes, which you would expect because the visceral fat produces the estradiol. This is another one of those situations where people do not understand that observation does not prove causation. When you observe that the high levels of estradiol portend harm, that doesn't mean that it caused it. It means it's associated with it. But, of course, those men that have a high estradiol have increase in visceral fat, increase in dyslipidemia, increase in blood sugar, increase in inflammatory markers. That's why they have the cardiovascular disease and the increase in MI, not because of the high estradiol. In every situation, as I've taught you in the courses, high estradiol levels that result from giving testosterone or high estradiol levels resulting from giving estradiol have all been shown to be beneficial to men, not harmful. So high baseline levels are associated with it. Yes, that's true. High baseline levels of beta estradiol are associated with heart disease and breast cancer in women. But yet when you intervene and do interventional studies, no study shows that when you give estrogen, is it harmful in women? No study shows that when you raise estrogen in men, it's harmful. Do not extrapolate the purported harm of baseline to what happens when you give it and intervene. Those are two completely different circumstances, and they need to be separated, but some doctors cannot separate it in their brain. Recent studies have described a relationship between low levels of endogenous testosterone and atherosclerosis, coronary artery disease, or cardiovascular events. Men in the highest tertile of testosterone had lower relative risk and less aortic atherosclerosis than men that had lower levels of testosterone. Pretty much every study shows this. Olson observed that both serum testosterone levels and sexual binding globulin levels are inversely related to atherosclerosis and major cardiovascular events. The higher the testosterone, the better the benefit. The higher the sexual binding globulin, the better the benefit. The lower the sexual binding globulin, the worse the benefit. And people want to lower sexual binding globulin because it increases binding of the free. Well, just give more testosterone. Well, you can't because they don't qualify for it. Don't get caught up into this, they don't qualify for it, because that's a dead-end street. In a recent paper, one author described an association between low levels of serum testosterone and premature coronary artery disease in men 45 years of age or younger. So don't wait until 65 and then try to treat it. Really, the age we should look at is 40 to 45. That's when the disease starts, and don't let it progress for 20 years before you try to cause an abrupt change in the progression. Patients who had low levels of testosterone were more likely to demonstrate atherosclerotic plaque, endothelial dysfunction, and higher levels of C-reactive protein and inflammatory markers produced by visceral fat. Therefore, a host of observational studies suggest an association between low levels of testosterone and the presence of atherosclerosis and coronary events. The goal of testosterone therapy is to restore testosterone levels to the normal physiologic range, and I will add to that of a young adult, and to reverse the physiologic effects of hypogonadism. You will notice in some studies where they used a transdermal commercially available testosterone, they didn't see much change in lipids or much change in cardiovascular improvement. All those studies that tend to show improvement are in the studies where they used relatively high doses and achieved high levels of testosterone that were primarily found with the injectable testosterone and not with a commercial available preparation of testosterone such as androgel, testim, or Axiron. Testosterone therapy has been shown to improve symptoms of sexual dysfunction. Complaints of changes in sexual dysfunction, including ED, ejaculatory dysfunction, reduced libido, are among the most common presenting symptoms of hypogonadal men. And of course, we doctors are really good at saying, well, you don't qualify for treatment. You mean you got to live with this? Yeah. Really? Well, then you need to go see another doctor. Mood, depression, cognitive changes have been widely reported and associated with low testosterone levels. We feel and function better when we replace it, but you have to replace it with enough to a relatively good level in spite of the most recent restrictions trying to prevent that from occurring. Fatigue is another common complaint seen in hypogonadal men. Almost all men over 50 will have some element of fatigue. Fatigue and vigor improved in a trial of testosterone therapy. Testosterone has been extensively studied for changes in muscle mass and body composition. It maintains muscle, it burns fat. There's no drug that the cardiologists use to achieve that. And yet, what they really should be doing is achieving this. There's another Cardiometabolic Summit scheduled for this October. And I looked through the schedule, and of course, there's not one lecture on hormones and cardiovascular disease. It's all drugs, medications, lifestyle, weight loss, etc. And unfortunately, the reason for this type of summit is because the cardiometabolic world has been unsuccessful in curbing the disease progression. They completely miss that it's the reduction in visceral fat that's important. Majority of these studies of body composition in hypogonadal men showed improvement by testosterone in lean body mass, decreased subcutaneous fat, decreased visceral fat. In a recent study, those men treated with testosterone that also had resistance training had a decrease in fat mass, increase in lean body mass, increase in strength. Corona et al. Reported that testosterone contributed to reductions in body fat, glycosylated hemoglobin, fasting blood sugar, and triglycerides. What a great drug it is to do all of these things, and yet it is so resisted by, I'll use the word pundits, that pretty much ignore and don't understand the science and the literature. One of the negative studies was the TOM trial, and I will review that. The TOM trial was a placebo-controlled randomized study, so it had a good design, study to assess the effects of administering testosterone gel. Adverse events were monitored by this board that stopped the study early because of a higher rate of cardiovascular events in the treated group. Unfortunately, they did not exactly define events. Why did they say event? Why didn't they say MI? Why didn't they say death? They called it an event. So some were major events, such as myocardial infarction, but often were softer events that were truly not cardiac, that perhaps were caused by the testosterone, like edema. Well, testosterone causes edema. Another soft event was syncope. Another soft event was elevated blood pressure. Those were soft events that were included, as opposed to looking at the hard events, which were MI and death, like all the other studies. So the limitations of this study were pointed out, and that the participants had a high prevalence of chronic conditions already, pre-existing cardiovascular disease, but there was an increase in events, but the events were soft events that really had nothing to do with cardiovascular disease itself, but due to the testosterone, and they were counted as cardiac events, but they were really non-significant cardiac events. When you look at real cardiac events, there was no increased risk of cardiac events. That's the flaw of the study. Also, it's not possible to extrapolate these findings to other formulations or doses of testosterone. So even though that study showed increase in events, it did not show an increase in hard events, and the design of the study should be criticized. The second study is the vegan study, which most people are aware of now, and this studied the relationship between testosterone therapy and all-cause mortality, MI, and stroke. This study has stirred much discussion also because of its poor design. Some investigators pointed out that the raw data, before it was tweaked by statistical adjustment, actually showed an outcome that favored testosterone. Yes, the outcomes were better in the testosterone group than in the controlled non-testosterone group. But when you look at the raw studies, the raw numbers, and see that the event rate was half, you question how could they come up with a study that showed harm when the raw data shows benefit. It makes
Hang on, everyone. It looks like we've lost Neal just momentarily. Bear with us.
Are you there?
Yes, we can hear you now.
Thus, if one looks at the raw numbers, testosterone was associated with an event rate that was reduced by more than 1/2. And it wasn't until statistical manipulation that the opposite conclusion was reached, which again is a significant flaw in the study. Another criticism of the paper included the concern that men with MI or stroke were given testosterone after these events were excluded from the analysis. And had they really been included, the events in the no treatment group would have been substantially increased. Again, significant flaws in the design of the study, and everyone just sort of overlooks those flaws and say, well, it was a study that showed harm, and everyone wants to hang their hat on it. We don't see this criticism for the studies that showed benefit. The criticism is for the studies that showed harm, and these studies are essentially flawed, which is why the FDA has not come out with any substantial advice not to use it based on the factor of this increased risk. Some investigators have called for retraction of this paper. Yes, there's over 30 medical societies that have demanded retraction of this, but JAMA has refused to retract this. A third study contributed to the controversy. It was the Finkel study, and in this, testosterone exposure was defined as a patient who received a prescription for testosterone. That's a really poor study. Well, here's a prescription for it. We don't know if you took it, if you didn't take it, and then we looked at the results, and it showed an increased risk in those that were given a prescription, but we don't even know if they took it or not. A recent study compared cardiovascular events in men receiving various forms of testosterone therapy. Injection therapy was associated with a higher event rate than the topical or transdermal preparations. But again, this study was criticized because they didn't have a control group for comparison, which again is a significant flaw in the design. So it's these four studies with all their design flaws, everyone wants to hang their hat on, but the FDA fortunately has said, you know, these studies are very weak, they're flawed, they're subject to error, and the amount of studies that showed benefit should not be overlooked. And at this point in time, they have not recommended restriction of the use in men that have cardiovascular disease. Despite these recent studies showing an association of adverse cardiovascular outcomes to testosterone use, there's an equal number of studies showing just the opposite. Shores et al. reported in men receiving testosterone, the death rate was significantly lower, and the risk of MI was also significantly lower. Valerian also reported there's no increased risk of MI in his study with the use of testosterone. Multiple other studies show the same thing. There have been a few clinical trials that have focused on the use of testosterone replacement in men with diabetes or the metabolic syndrome. And in all of these studies, they showed reduced insulin resistance, improved survival, decrease in cardiovascular events, and reduced ischemic burden. So when you look at the other side of the coin, by not prescribing it and by restricting the use of it, we're actually doing harm when you look at all the other studies and the tremendous amount of data that's involved. That's why I showed this study that adequately describes the controversial studies, the flaws in them, but also the studies that show benefit that we should not ignore. Results of this recent meta-analysis on the effects of testosterone and cardiovascular risk have been contradictory. One study, which was a meta-analysis, suggested that testosterone increases adverse cardiac events. Another study showed that testosterone was not associated with major cardiac events. It was actually protective in men with a metabolic syndrome. So you can see how it's controversial. But the concern is in doing a meta-analysis. A meta-analysis, you can pick whatever studies that you want to prove your point. So looking at a meta-analysis does not necessarily show that it's harmful, does not necessarily show that it's beneficial, because it's the opinion of the author that you get and the studies that they looked at. And if they had an agenda, then you're going to see the outcome based on their agenda. One recent retrospective study examined the effect of testosterone on normalization of testosterone levels. Optimization, normalization, bring the levels back to normal of a young adult, and the effect on cardiovascular outcomes. Patients who received testosterone achieved normal levels had significantly lower all-cause mortality, lower risk of MI, lower risk of stroke, in comparison with those that took placebo or no testosterone. As a result of all of these recent beneficial studies, the U.S. FDA convened an advisory panel to review the use of testosterone. The panel concluded that there's not enough evidence that testosterone was a significant harmful therapy that increased risk of cardiovascular events in selected individuals. In March 2015, the FDA clarified the recommendations for the use of testosterone therapy and stated that it's approved only for use in men with documented testosterone caused by specific medical conditions. I don't understand that. So if you have a specific medical condition that lowers it, it's okay, but if you don't have a specific medical condition, then it's not okay. Yeah, but what about the patient that suffers with the symptoms? Well, they don't qualify. That's cruel and inhumane, but that's how they restrict. I don't even want to get into that. That's a whole other lecture. Nevertheless, the FDA required manufacturers to change the labeling to include additional warnings. If the FDA does not include these warnings, then they are at fault. When they do include these warnings, everyone jumps on the bandwagon and says, see, there's harm there, there's harmful effects. Whereas all the FDA was saying, yes, there's these studies did show harm, but the studies are severely flawed, but we need to tell you about those studies. These caveats include testosterone is indicated for replacement therapy only in males with conditions associated with a deficiency in endogenous testosterone, and they have some sort of medical disease or entity that's causing the problem. Well, most men don't have a disease or an entity that causes the problem. They just have low levels based on age. And the FDA is trying to say, well, you can't use it for that anymore. Testosterone has a role in therapy of truly symptomatic hypogonadism in both young and older men. There's no major concerns for use in young, healthy men with specific indications, and that is a disease process. And that's the new indication by the FDA, which is intended to restrict the use of it, unfortunately. So that's the first paper showing the studies that showed flaws, the studies that showed benefit, and the fact that the FDA has not found that it should be restricted based on cardiovascular disease, but they've restricted it based on the fact that they want to restrict it for political reasons. Now let's look at some other articles. Optimal androgen levels are a biomarker for survival in older men. Mid-range levels of testosterone and DHT have the lowest death rates from any cause, and those that had DHT levels in the highest quintile have the lowest ischemic heart disease mortality. Where would you like your levels to be? Well, I want mine high as opposed to low. Another study showing the higher the level, the better the effect on morbidity and mortality. The lower the level, the more harmful the effect. Subjects supplemented to high testosterone had a reduced 3-year major adverse cardiac event rate to 0.5 and death rate of 0.3. That's a significant decrease in MI and death in men that were treated with testosterone that received relatively high levels in their serum. There is absolutely no signal for an increased risk of major adverse cardiac event or death with higher testosterone. There was no attenuation of the effect either. In other words, the higher the level, the more beneficial the effect. It wasn't like you reached a plateau and above which it was harmful, or you reached a level above which there was no further benefit. No, there was no attenuation of effect. The higher the level, as high as they looked at it, there was still continual beneficial effects the higher that they went. Completely the opposite of what, unfortunately, the FDA tries to do when restricting the use of it and restricting upper end levels. In a large general healthcare population, testosterone therapy in men with low testosterone was associated with reduced major adverse cardiac events over 3 years in comparison with no supplementation whatsoever. It makes no sense for us to try to restrict supplementation when these studies show significant benefit when the levels are high. Another study by Hackett, this is a nice study. Urologists and primary care physicians are the most frequent initiators of testosterone therapy, usually for erectile dysfunction, fatigue, etc. The benefits are clearly established for sexual function, increase in muscle mass, strength, mood, cognitive function, reduced frailty, and osteoporosis. There's a recent article from PLOS One that was published showing that testosterone has no beneficial effects at all in improving sexual function, lean muscle mass, strength, cognitive function, depression, etc. Really? No, their conclusion was based on the studies that they looked at, there was no benefit. Yet these studies show significant benefit. Now you see it depends on, shall we say, the agenda of the author as to what the results of the study would be. Therefore, my point of contention is, just because a study says something doesn't mean that it's true, unfortunately. It can be backwards both ways. You can have authors that say it's harmful, it doesn't work, and you have authors that say it's extremely beneficial, it's well established in the medical literature of the benefits. That's a sidelight. The cardiovascular issues associated with testosterone therapy have been clarified by recent studies showing clearly the therapy associated with a clear rise in testosterone levels is associated with reduced mortality, reduced MI. It does not increase it, it reduces it. Yeah, but this one physician took testosterone and died. Yeah, but that does not mean that he died because of his testosterone that he was using. He died because of his disease that was so bad. What do we then do? Not treat anyone? That's ridiculous. So you have to look at the science and the research to show and support raising your level up by giving testosterone reduces mortality and reduces MI. Studies reported showing an increased risk have been subject to flawed designs and inadequate baseline diagnosis and follow-up testing. All of these studies that showed those four all have significant flaws that have been well demonstrated in the literature. The European FDA recommends testosterone therapy for men with symptomatic androgen deficiency. They focus on symptoms, not on numbers. And they have their testosterone approved to improve secondary sexual characteristics, improve sexual function, improve sense of well-being, muscle mass, strength, bone mineral density, depression, etc. In spite of the fact that some pundits on this side of the Atlantic want to restrict the use of it and say, no, it doesn't work, it doesn't do anything, and therefore you shouldn't use it. Yet it has FDA approval for improving those symptoms. Normal laboratory values vary considerably, adding to the difficulty of standardized definition. Even more confusion exists around what constitutes the symptomatic patient. Most recently, according to the FDA, symptoms do not define a symptomatic patient. Patients are defined by their numbers. We don't care how they feel. We don't care if they're symptomatic or not. We care about their numbers. Study after study after study shows numbers should not be used to restrict therapy because numbers don't define when a patient's going to develop symptoms. The urologist commonly deals with patients referred for sexual dysfunction, is well aware of the impact on the patient, whereas endocrinologists, and I would probably say the FDA, frequently fail to routinely assess and manage sexual dysfunction. They're concerned with numbers, and we don't care about the patient. Urologists, family practitioners, age management doctors, we care about the patient and how they feel and how they function, as well as their long-term health. Probably nothing could be more controversial in medicine than the issue of testosterone use in men. The BLAST study suggests that the early sexual benefits and improvement in aging male symptom scores in terms of energy levels, muscle strength, are the major reason for the treatment satisfaction. If it doesn't work, why do so many men get it? If it doesn't work, why do so many men stay on it? The multiple modest effects of testosterone replacement therapy equate to highly significant improvements in well-being that are greatly appreciated by patients and a major reason why men want to continue the therapy. Do those men really look at the paper published in PLOS and say, oh, maybe we should stop taking the testosterone, it didn't work, it doesn't help us? No. Well, then it sort of makes the people that publish those articles look foolish. What does this mean for clinical practice? Patients with hypogonadism present with distressing symptoms associated with poor quality of life. That's why patients go to see doctors, so that we can improve their quality of life. They rightly expect the physician to be motivated to treat the symptoms rather than performance targets or numbers. Testosterone therapy is associated with a modest improvement in a range of symptoms that might add up to huge benefits to the patient that might be underestimated by specialists with a defined area of interest, i.e., those that want to restrict, i.e., the endocrine community, because they don't qualify based on these numbers. Shame on us. When testosterone therapy has been initiated by a urologist, usually for sexual dysfunction, therapy may be discontinued because of a rise in PSA. Despite strong evidence that testosterone does not cause prostate cancer, does not cause prostate cancer to grow based on the saturation model. But I see doctors every day stopping testosterone on patients because their PSA goes up. We do the workup. They don't have prostate cancer, but they say, oh, no, don't take testosterone because it caused the PSA to go up. PSA is a protein that goes up because of BPH, prostatitis, etc. Testosterone does not cause prostate cancer and should not be stopped in symptomatic men. In fact, the U.S. Preventive Services Task Force now says don't measure the PSA. The patient will be deprived of multiple potential benefits of testosterone because of a transient elevation of PSA despite no evidence to the contrary that it increases cancer growth or cancer risk. Recent evidence suggests that low testosterone may actually put the patient at increased risk of higher grade cancers. Yes, absolutely true. The lower your level, the greater your risk. The lower your level, the greater the grade of cancer. A recent study recently done at Hopkins showed that men who have biopsy-proven cancer that received massive doses of testosterone, I will quantify that with massive doses of testosterone as one shot a week. In those men that received one shot a week of testosterone, the PSA levels fell in over 50% of them, and several of the men showed that their cancer entirely resolved. The confusion by these researchers was why it worked. And of course, for those of you that have been through Part 3 and Part 4, understand the reason it worked was probably because of the increase in estradiol level, and it's the increase in estradiol level that is apoptotic to prostate cancer cells. So the results are not confusing or surprising to me, but the results are very confusing and surprising to the researchers that found that. Trials of treatment need to be for at least 6 and ideally 12 months to achieve levels in the mid to upper normal range, and that's typically where we're going to see the improvement or loss of visceral fat, improvement in dyslipidemia, and improvement in blood sugar parameters. Most importantly, the impact of treatment has on the overall quality of life of the patient and his partner, and that's the reason that they continue treatment, but it takes at least 6 to 12 months before we see complete improvement in these parameters. There's a strong and consistent body of evidence that testosterone replacement therapy for appropriately diagnosed hypogonadism is safe, efficacious, and probably associated with reduction in cardiovascular risk and all-cause mortality. I've shown you several articles where in secondary studies there's a decrease in cardiovascular risk, there's a decrease in all-cause mortality. It does not increase MI, it does not increase the heart attack just because one patient experienced it. Crucially, studies assessing mortality based on appropriate diagnosis achieving target therapeutic levels consistently show reduction in mortality. Two high-profile studies showing increased mortality were flawed by lack of definite diagnosis and no evidence of adequate treatment. Yet all these other studies show significant reduction in mortality and MIs, but we ignore those studies and we want to hang our hat on flawed studies. Patients generally choose to take and continue testosterone therapy because of symptomatic improvement and improved quality of life. To restrict that based on our lack of understanding of studies is really unfortunate. Unfortunately, a few poorly designed studies from the U.S. with inadequate diagnosis and follow-up apparently showed increased risk for testosterone therapy. These received inappropriate high-profile coverage where their methodology was severely flawed. Another study showing significant flaws, but yet everyone ignores it. Let's look at some other studies. Long-term testosterone therapy improves cardiometabolic function and reduces cardiovascular disease. This is a great study, published in the Journal of Cardiovascular Pharmacology and Therapeutics, 2017. In the control group, there were 21 deaths, 19 of which were related to cardiovascular disease. There were 2 deaths in the testosterone group, none of which was cardiovascular related. 21 in the placebo, 2 in the testosterone group, not cardiovascular related. The estimated reduction in mortality in the testosterone group was between 66 and 92%. There were also 30 non-fatal strokes, 26 non-fatal MIs in the control placebo group, none in the testosterone treated group. Which group would you like to be in? Yeah, but testosterone causes heart attacks. No, it doesn't. It causes strokes. No, it does not. Look at these studies. Look at the results. This is long-term testosterone injections, was well tolerated with excellent adherence, suggesting a high level of patient satisfaction. Mortality related to cardiovascular disease was significantly reduced in the testosterone group. What is it that we don't see or understand or learn or appreciate in these studies? I don't understand how they can ignore these studies and how they want to hang their hat on. Well, this one guy got a heart attack. It's not surprising that his published reports demonstrate that testosterone therapy ameliorates metabolic syndrome, improves lipids, lowers blood sugar, lowers blood pressure, decreases systemic inflammation and inflammatory markers in visceral fat, lowers insulin resistance, improves muscle mass, lean body mass, and reduces waist circumference, visceral fat, subcutaneous fat, improves vigor and vitality, and it reduces mortality related to cardiovascular disease. How can you ignore this? Why would you want to restrict that? It makes no fucking sense that somebody wants to do that. And yet, every morning I wake up and there's some pundit with some other article on how bad testosterone is and that you shouldn't use it, and they completely ignore the other side of the coin, and they don't understand the harm of restricting the use of it. Over the past several years, 4 reports appeared in the literature. I've gone through this, purporting increased risk of death. A thorough analysis of these studies has been undertaken by several investigators, including the FDA, all arriving at the conclusion that these studies were neither credible or convincing with regard to purported cardiovascular risk due to methodology flaws, data contamination, unvalidated statistical methods, etc. We don't see any of those comments on any of the studies that showed benefit. 7 recent studies did not confirm the findings of these purported studies. On the contrary, none reported an association with testosterone therapy or increased cardiovascular risk or increased mortality. A recent randomized controlled trial of 790 men looking at treated and untreated with testosterone for a year confirmed no increased risk of cardiovascular disease. How many of these studies do we need to see? On the contrary, in the second year follow-up, the study showed more events in the placebo group than in the testosterone treated group. Study after study after study after study shows the same thing. Why do we ignore it? Impact on blood pressure. It's interesting. I've seen or heard from one or two practitioners that have said, my patient was on testosterone and blood pressure went up. So does testosterone increase blood pressure? Well, maybe it did in that patient, but maybe it didn't because that was just the natural course of the disease. People have increased blood pressure every day that are not on testosterone. Well, then you need to look at the studies. And the studies show that there's a significant reduction of blood pressure, both systolic as well as diastolic. There's unloading of the heart. There's reduction in nitric oxide, all resulting in decreased cardiovascular disease. That's the low levels of testosterone are associated with increased risk, and physiologic testosterone levels are associated with a protective effect on the vascular system, including blood pressure. A number of observational studies have demonstrated that testosterone therapy reduces mortality and improves cardiovascular risk factors, reduced fat, obesity, waist circumference, blood pressure, and improvement in glycemic control. I'm not showing you this one study. These are different studies showing the same identical thing, even though it's repetitive. Hopefully the repetitiveness emphasizes the benefits that are there that everyone tends to ignore or doesn't see because they don't look at the studies or the literature like I do. Assessment of testosterone on these chronic conditions requires long-term randomized controlled trials with long duration approaching a decade in order to truly assess what happens in real-life settings. So the FDA has said that it is required that the manufacturers do this study, which is presently ongoing. Unfortunately, it's going to be a very long study, and in order to do such a long study, it requires 10 years and thousands of patients. Unfortunately, this is not feasible, and most of the randomized controlled trials are of a shorter duration, but that's all we got. So how do you then bridge the gap between a long-term randomized control trial and these short randomized control trials? Well, you do registry studies, and that sort of bridges the gap between the randomized control trials and real life, and that's what this study did. In this report, we present data from an observational registry study that were men followed up for 8 years. Testosterone therapy was shown to reduce the risk of incident MI, stroke, and mortality. These reports, together with the meta-analysis published by Corona, suggest that there's no credible or substantial evidence that exists for an increased cardiovascular risk with testosterone therapy. Thus, we point out that the earlier reports that purported an increased risk are confounded by methodological flaws, without adequate clinical acumen that makes them inconclusive and at best suspect in their conclusions. Study after study after study shows the studies that everyone wants to hang their hat on are severely flawed and should be thrown out. And yet everyone ignores the studies that show benefit. Considerable clinical benefits of testosterone therapy cannot be denied, such as sexual desire improvement, erectile function improvement, improved energy, mood, vitality, etc. Study after study after study shows the same thing. Low levels increase risk of death. A number of studies showing that testosterone improves these risk factors. I won't be redundant. Improvement of blood pressure, dyslipidemia. All of these factors are important in reducing the risk, but you still need to do outcome studies. For Beyond Hormones, which is going to be part 5, I'm going to have one whole day of all new lectures on hormones that I've not been able to show in parts 1 through 4. And I'm going to go through and review all of the studies showing reduction in cardiovascular disease and carotid intermediate thickness. The cardiovascular world is head over heels trying to find a drug that reverses intermediate thickness. Well, there's quite a few studies showing reduction of carotid intermediate thickness with estrogen, with testosterone, with growth hormone. All hormones, not drugs, and the amount of data and the reduction in intermediate thickness is tremendous, yet everyone ignores it. I don't understand why we ignore these studies that show you can reverse plaque, and there's study after study after study that shows it, in addition to reducing mortality. It's absolutely amazing what is completely ignored that's in our medical literature. So I'm going to review that in part 5. A recent large observational study by Wallace demonstrated that long-term testosterone has an inverse relationship between cardiovascular disease and mortality. The higher the testosterone, the greater the treatment, the less the cardiovascular risk. Study after study shows it. It's our view that such important findings provide support for the premise that testosterone reduces mortality associated with cardiovascular disease, and it really should be used as an add-on therapy by all cardiologists and the cardiovascular world. And right now, everyone's running scared and thinks that it causes harm, and they completely ignore the data and the studies that show benefit. It was really a shame. The marked improvement in blood sugar, reduction in hemoglobin A1C is consistent with all prior studies. This study looked at particularly diabetics and those that have insulin resistance. Pretty much, most men over age 50 that have heart disease have an element of insulin resistance that can be completely reversed with testosterone. It's a physiologic hormone. When administered in physiologic levels, produces reduction in blood sugars, no significant serious side effects. Yeah, there's an effect on fertility. Yeah, there's an effect on one or two things, but on testicle size. But overall, health-wise, no significant adverse effect. Pronounced benefits on cholesterol and lipids. No significant changes were noted in the untreated placebo group, yet in this long-term study, there were significant improvements in all lipid parameters and blood sugar markers and triglycerides that we completely ignore. What a great drug it is without having to resort to the drugs and the side effects of the drugs. Dyslipidemia, a significant risk factor for cardiovascular disease. There's normalization of dyslipidemia. It's such a great drug, and everyone ignores it. More importantly, the triglyceride total cholesterol HDL ratio is significantly improved. There's no other drug that does this. You got to knock down the visceral fat, and how to knock down the visceral fat is with very good doses of testosterone. Those good doses that result in high levels of testosterone are now used by certain endocrine societies to try to reduce the use of it, which is really a shame. And as a result, if it gets restricted, it will no longer be a beneficial treatment to reduce cardiovascular disease if you use such low levels. This group also looked at systolic and diastolic blood pressure as others, showing significant benefit in blood pressure, no significant changes in blood pressure in the control group. Look at all the benefits of it, and yet we completely ignore it. The reduction in rate pressure that you saw by the release of nitric oxide in the testosterone group should not be ignored. A decreased myocardial workload. The data presented clearly demonstrates that testosterone produces profound effects on anthropometric parameters, visceral fat, lipids, blood sugar, inflammatory markers that you don't see with any other drug. There's an improvement in body composition. There's no treatment that the cardiologists do to change body composition. And that's really the key to it, reducing this visceral fat mass and improving and increasing lean body mass. It's critical this increased lean body mass improves basal metabolic rate, blood sugar, overall health and mortality, and yet it's completely ignored. And we're afraid because one person had a heart attack. We're afraid because, well, someone says. There's a considerable body of evidence accumulated to suggest that testosterone does not increase the risk of heart disease. A recent review by this one doctor, Ho, tabulated studies on testosterone in men with hypogonadism, and they suggested an increase in cardiovascular endpoints. They did not favor testosterone over replacement. But when you looked at the actual studies, they did. The authors of this review formulated their own conclusion based not on the actual data in their studies, but based on preconceived ideology. Now you can see how your bias can factor into what the studies show. This review either ignored or overlooked the findings of the many studies, many of the ones that I've showed and introduced. They didn't even look at in their review, which is really a shame. In contrast to the majority of studies, patients in the testosterone group achieved 100% medication adherence in this one study, and that's of paramount importance. They didn't see that in the other studies. They didn't see that in the vegan or the Finkel study. We believe that the protective effect of testosterone in the cardiovascular system provides clinicians with the opportunity to utilize this approach for secondary prevention. No, it doesn't cause an increased risk of heart attacks. It should be used as an add-on for those that have heart disease in order to decrease heart events or cardiovascular mortality or death. but yet everyone's afraid of it. So I hope that these studies give you better confidence in prescribing it, confidence in treating men with pre-established cardiovascular disease. Unfortunately, those men will still die from their disease. Unfortunately, many doctors will still think that it's harmful, whereas there's probably nothing better than we could do for these patients. And then how do you then figure it out? You rely on the studies, you rely on the data to support why we do what we do, and not from one or two pundits or one or two studies that are severely flawed, which everyone wants to hang their hat on. So I hope that you get a better appreciation for, yes, we should optimize therapy, don't restrict it, and don't restrict using it in men that have cardiovascular disease or a risk for cardiovascular disease, thinking that it may cause harm when in reality it does not. It will provide benefit in all the studies that I showed. That concludes today's discussion. I'm going to now entertain questions.
Can I interrupt for a moment, Neal? Again, for those of you that have joined us, please note in the lower right-hand corner of your screen, you should see the question and answer box where you can enter your questions to Neal. Back to you, Neal.
Steve Gershon writes, hi, Steve. I have a patient who underwent a radical prostatectomy. He's interested in undergoing testosterone replacement therapy at the 5-year mark, which he will reach in 3 months. He's read all the articles that you have given to us. His testosterone level is non-existent. His concern is how can we effectively raise his testosterone levels past the saturation point without running the risk of feeding any cancer tissue that may have been missed in the surgical procedure and through external beam therapy. His PSA remains 0. Would I consider estrogen therapy? I'll go backwards first. No, I wouldn't consider estrogen therapy in him because he doesn't have any evidence of active disease. I only use estrogen when there's evidence of active disease, meaning that his PSA is rising. If he's 5 years out and his PSA is still 0, he is cured. He does not have one little cell hiding out there that's going to grow. He would have seen that by now. The path report should have shown extension beyond the capsule. And if it was, we would see the PSA rise after about a year. If they're 5 years out, and I wouldn't wait 5 years, but if he's at the 5-year mark, he is absolutely cured. He does not have cancer at all. When you go and look at those studies at 5 years, there's no risk of testosterone causing growth of a cancer that does not exist. In the studies less than 5 years, like 1 year, even those that are treated with radiation, we do not see any recurrence in men that were given testosterone. Let's take it even further. Now we have men with active disease, proven biopsy results, not treated with surgery or radiation, but have active disease that's being observed. They're in that wait and watch category. Can we give those men testosterone? Well, the PDR says absolutely not. However, the studies show that yes, you can, assuming the PSA does not go up, which it doesn't in the majority of the studies. It goes down. And if we don't cause an increase in prostate cancer growth in men that have active cancer growing that are not treated, why are we afraid to use it in someone that has a PSA of 0 after 5 years that has no prostate tissue whatsoever? Again, this fear of the reaper, the fear of this one little cell growing, unfortunately, if you believe that and don't treat this man, he's going to succumb to cardiovascular disease, cerebral vascular disease, Alzheimer's disease, dementia, diabetes, dyslipidemia, etc., because we're afraid to give him testosterone because he's afraid to take it. And unfortunately, that fear is, as I discussed in the one article that I just showed you, a significant concern, particularly in patients that have had prostate cancer, or it's a concern of doctors that it may cause cancer to grow that's undiagnosed. We don't see that in any study. So imagining it is not evidence-based medicine, and based on all the evidence-based medicine, yes, I would absolutely treat him, and I wouldn't wait for his 5 years to be up. I would treat him yesterday. No, don't use estrogen for prostate cancer that has been treated or cured. I only use estrogen for prostate cancer that is growing outside the capsule that is now showing no response to LHRH agonist, radiation, or brachytherapy. Go treat your patient, Steve. Dr. Fornesi says, would love to see the last slide again about the requirements for diagnosis and treatment. It'll be in the webinar. All you have to do, Darren, is go to the webinar and you can look it up. Again, these are the most recent requirements from the FDA. When it was originally FDA approved, 40 years ago, it was FDA approved in an injectable form to treat symptoms. When it was approved in a transdermal form in 1999, again, it was FDA approved to treat symptoms. And if you look at the landmark article from JCEM in 1999, it states that there's no biological parameter that denotes a deficiency, i.e., there's no number that denotes a deficiency, because different patients will have different receptor site resistance and different levels, and they still may not have symptoms or may have symptoms. So numbers should not be utilized based on all the studies. That's going to be another upcoming webinar. Numbers should not be used to restrict therapy, but yet the FDA wants you to, and that's why they've come up with these new guidelines. They don't want you to use it on older men that are getting it just for symptomatic improvement. They don't want to improve symptoms. Again, Congress has told the FDA, stay out of the practice of medicine and don't dictate to doctors how to practice medicine, but this is another example of how the FDA is trying to restrict the use of it and dictate to doctors how to use and prescribe medicine. There's a recent article, however, that showed that this recent restriction by the FDA, by making testosterone only FDA approved for use under these guidelines, does not necessarily mean that you cannot use it or prescribe it. If you use it or prescribe it, you're using it for off-label use. This article went on to say that 90% of the prescriptions used in men are for off-label use. Well, the FDA is concerned about this. Well, 50% of the drugs that we use in everyday practice are for off-label use. They don't have an FDA approval for that use, but we still use it for those things, and it is very legal to use it for off-label use. So don't get caught up in the FDA requirements for prescribing. You may see that as far as insurance companies want documentation before they will authorize payment of it, but I completely stay away from insurance companies, and I don't fall into their game of using numbers to restrict the therapy. Karen McDowell asked, how do you treat or prevent prostate hypertrophy in older men taking testosterone replacement? Let me do that one first. Testosterone does not increase BPH. There's a recent meta-analysis that showed that testosterone does not increase BPH. I'm going to show in the upcoming Part 5, Beyond Hormones, the data showing that testosterone actually decreases BPH, and it does so by an increase in, I know you're not going to like this, estradiol. The study went on to say that it's the use of estradiol that actually shrinks the prostate tissue and actually protects against BPH and BPH symptoms. I know that's completely the opposite of what you've been misled to believe. I just look at the studies and the literature that shows that testosterone does not increase BPH, and neither does estrogen. In fact, it's the estrogen that really is resulting in the decrease in the BPH. And we know that by using estrogen alone and seeing the effects that it has on the prostate. Is surgery the best treatment, or is it more common with testosterone replacement? I don't think surgery is necessarily the best treatment. Many men get BPH as they get older. I like Flomax or Tamsulosin, which relaxes the smooth muscle, but also Cialis has been FDA approved to help reduce BPH symptoms also. So you can use Flomax, Cialis, and testosterone and optimize your testosterone and get your estradiol level up, all that will help improve symptomatology based on these studies. Is there replacement discontinued commonly with prostate hypertrophy? No, I never discontinue testosterone in anyone that has BPH. Even though it is contraindicated because it says so in the PDR, the literature shows just the opposite. Kim Hansen asked, will these slides be available to download and print? Yes, if you'll contact Mary at MedQuest, and this webinar has been recorded, so you can get the slides from it as well as the recording from it. Jaron says, so am I saying that when the FDA now considers testosterone replacement therapy off-label unless it's used for a disease causing the low testosterone? Yes, that is what I'm saying, and I think that's what the FDA is saying. And that we should use off-label consent? Yes, you should. And I mentioned that in the courses, that anytime you use testosterone, that you mention to the patient, you document that you told the patient, and you document it in your consent that it is for off-label use. I want you to, that should be emphasized. Because sooner or later somebody's going to say, well, did you advise them of off-label use? And you can say, yes, I said it right here. Well, did you tell them? Yeah, I said it right here. Did they sign the consent? Yes, it says it right here. Is it in your note? Yeah, it says it right here. I prescribe testosterone to help improve symptomatology and quality of life, and at the patient's request. I'm using it for off-label use, and I've advised the patient of that, and I've documented that in my note that it's for off-label use. Rich Sherman, hi Rich. I hope you're not bothered too much by the road closures up there in Big Sur. Dr. German asked, how do you approach the adamant MD bias versus testosterone therapy? I don't approach it. You can ride one of two horses. You can't ride two horses at the same time. If the PMD is adamantly opposed to it, I don't try to change their mind. You're not going to be able to change the religion. They won't change the religion, and they won't change their mind. Once they're dead set on the world is flat, once they're dead set on testosterone should not be prescribed, it's harmful, it's bad, 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 you cannot change that person's opinion no matter how hard you try. You can let them listen to this webinar. Worthless. They're not going to listen to it. They could care less. You could show them all the articles that I presented in the last hour. They're going to throw them in the trash. They could care less. All they know is it's harmful, it's bad, and don't use it. You are wasting your time if you try to change that. So my suggestion is you don't. You just move on. If the patient wants to take it and improve quality of life, then I'll be happy to prescribe it. But I won't get involved with the family doctor, and I won't be arguing with the family doctor, and I won't be in this tit for tat that the patient wants to put you in. Nope. If you want to do it, fine. But my doctor says, well, you do what your doctor says. He says I shouldn't use it. Don't use it. Yeah, but then I don't feel well. I know. How's that working out for you? They want to do bypass surgery and give me all these drugs. Great. Good for you. Hang in there. I don't argue with them. Denora asked, how steadily nitric oxide is released with testosterone supplementation? I don't know. I have no idea. Is there a test to measure it? Well, they've done ischemia studies showing that with testosterone you reverse ischemia. I don't know how fast that works, but yeah, it's in the literature where it has been shown to reverse ischemia. Any additional nitric oxide recommendations? I don't have any other than nitroglycerin. Bella Tennessee asks, so how do we as clinicians document to protect ourselves given the FDA's stance and their general belief due to the flood studies that it causes increased cardiovascular risk? Well, you document just as I said, based on my review of the literature, that I do not feel it is a risk. The FDA does not feel it is a risk. Otherwise, they would put significant black box warning of increased risk of heart disease. There's an increased risk of blood clots. I'll do that also in Part 5, looking at why does the FDA say there's an increased risk of blood clots, whatever that means, but how to get around that and why it says it. And I document that the literature shows that there's no increased risk, and that the literature shows that there's a decreased risk. The FDA's stance, again, is against the drug companies that over-marketed their products, and the FDA is getting back at them, spanking them for over-marketing their products for unapproved use. And now, as a result, the FDA is trying to restrict that use, but that's on commercial products, which many of us simply don't use. So compounded hormones are, again, off-label use, and that you've discussed it with the patient, the off-label use of the hormones and the benefits shown in these studies. How would I defend it in court? Just as I've mentioned it to you. Hi, Pete. Pete asked, can you comment on the Mayo Clinic's Proceedings article by Dr. Morgenthaler at all on testosterone therapy and cardiovascular risk. I think I reviewed that article in one of the prior webinars. Again, Morgenthaler does a great job at showing that there is no cardiovascular risk. He discusses the flawed studies. He discusses the studies that show benefit, no increased risk, in fact, a decreased risk, and that it should basically be a therapy that should be used as a second-line therapy for cardiovascular protection. He basically reiterates all the things that I did in the last hour's lecture. Did the FDA not see this list of resolutions? I'm sorry, but the FDA does not look at resolutions. Oh, I see which one you're talking about. His list of resolutions. Well, why did they do the resolutions? So that we practitioners can see and understand what to do in spite of the fact that there's pushback from the FDA against it. There's pushback by the Endocrine Society because the FDA dictates to them that they have to. There's pushback from pundits that don't like it, and that's their political opinion and their right to do so. And unfortunately, the resolution by Morgenthaler that provides us with good reason to prescribe it without fear or any harm of it is pretty much ignored by all these different groups and pundits. But what we can do is stand by our literature and our science that show that it's safe. The good news is I'm actually working on producing another article, and we've actually we're going to submit it to Mayo Clinic Proceedings to see if they will publish it just like they did Morgenthaler studies on the resolutions. It's going to be an article on resolutions for testosterone in women. And we basically follow the same format as Morgenthaler did. And I painstakingly went through it and looked at the literature and provided articles that support the use of testosterone in women, just like Morgenthaler used his articles to support the use of testosterone in men. And hopefully we can get that published, and we will see hopefully an article that will allow physicians to gain confidence and understanding of the importance of testosterone in women, not just in men. Darren writes, okay, thank you. You're welcome, Darren. Elaine Phillips says, I've had 3 patients this month whose PSA has doubled and the free PSA lowered. Can you comment on where to head with these? These patients had pellets. In the courses, I review how to work that up. Testosterone does not cause an increase in growth of cancer. It doesn't mean it won't cause an increase in PSA, which again is a protein that's produced in the prostate. With BPH, prostatitis, exercise, sex, jumping jacks, medications, all of which can improve or increase the PSA. When you look at the studies showing that testosterone does not increase the growth of prostate cancer, the increase in PSA is probably secondary to BPH. How would I do it? I would go through a workup as I would explain in the courses. And the first interventional study that I would do would be an interventional study on the use of Bactrim and Septra and watch the PSA fall back down to the normal range. That's why the U.S. Preventive Services Task Force does not recommend PSA testing anymore. I do recommend it. I still do it. I will still do the workup because I want to diagnose it sooner than later. But they don't even recommend doing a PSA test on these men because of the increased morbidity and mortality with doing a PSA and resulting in a biopsy. I wouldn't biopsy these men. I would do the normal workup, and I go through that in the courses where I speak to that. It's too long of a discussion now. But I would still continue it, and I would do the workup, and I would definitely give them a trial of an antibiotic and then retest them in 3 months. Lori Rigg asks, is a very high DHT level harmful? I just reviewed an article that shows that the higher the DHT, the lower the cardiovascular disease. DHT does not predict or increase BPH. In fact, it's just the opposite. In the European studies where they used just DHT, not testosterone, but they used DHT transdermal cream, they have not found an increase in PSA. They have not found an increase in BPH, have not found an increase in BPH symptoms. One of our patients has a DHT level of 6,000. I think that's lab error. I would retest it. It doesn't make any sense. He and the consulting physician are concerned about the effect on his prostate. Sure. Yeah, but that's got to be lab error. I would retest it using a different lab. I don't know why it's so high. That it just does not make sense. You can't have a testosterone level of 1,000 and then have a DHT level of 6,000. Have a DHT level of 6,000, you can have a total testosterone level of 10,000. And that's certainly just not possible with the types and doses of testosterone that we use. So anyway, I would repeat it. I don't think that's a true value. He's also concerned about hair loss. If you're concerned about hair loss, then you can use finasteride or dutasteride for hair loss. Kim Hansen writes, looking forward to seeing you in August to restart the series. Great, yes, we start part 1, 2, 3, and 4 again in August. All of those courses, unfortunately, have changed because there's so much new material that I throw out and new stuff that I stick in. Ursula, can you discuss the risk-benefit of cardiovascular disease with synthetic testosterone injection, patches, gels, versus the transdermal compounded creams? I can't because there's no study on transdermal compounded creams. I just look at levels. So no, there is no comparison study, although personally what I see with the transdermal compounded creams is if you get your testosterone level up to 1,500, 1,800, your estradiol level over 100, you will see a rise in the HDL, you'll see a lowering of the LDL, and a lowering of the triglycerides, a lowering of C-reactive protein and all the inflammatory cytokines. But you typically will not see that if you keep your testosterone total of around 400 to 500 as you would with androgel or any one of the commercial available testosterones. Most of the cardiovascular benefits that you see with these long-term studies are with the synthetic testosterone injections, typically not with the patches or commercial available products because it's just too long of a study to do. That's why they use the testosterone undecanoate, the long-acting testosterone, in these studies. But there's no comparable study using the compounded, only my personal anecdotal reports of what I see with the lipids. And I've shown you those lipid reports in the courses that I teach. In part 5, I will also look at the cardiovascular section, looking at reduction of intermediate thickness, looking at LDL particle numbers, and I'll show you the lab tests on how I lower LDL particle numbers, not with statins, but purely with hormones. And it's pretty amazing what you can accomplish by just giving them hormones. Todd House asked, are testosterone, cypionate, ethanoate bioidentical? Well, yes, they are, and no, they're not. It's a bioidentical testosterone. It's attached to a protein, which makes it sustained release, and it's the sustained release portion of it that has to go through the liver to be cleaved and metabolized that causes the adverse effect on lipids. So it will suppress the HDL, but so far we have not seen suppression of HDL with testosterone harmful, because the overwhelming effect of reduction of visceral fat and inflammatory cytokines overcomes that loss of, or the reduction in HDL that you see. Again, that's my preference in not using the injections, but rather using a transdermal compounded cream, which will maintain levels of 1,500 to 1,800 on a daily basis, as opposed to the injections, which result in a significant fall before your next injection. I don't see the adverse lipid effects with the transdermal creams maintaining serum testosterone levels of 1,500 to 1,800 and estradiol levels of over 100 on a daily basis that you typically will see with the injections, whose levels will fall depending on which one that you use. Are there liver implications for using IM testosterone? Theoretically, yes, but I don't really see any studies that have shown adverse effects. I've seen 1 or 2 patients on injectable testosterone that have had their liver enzymes go up. I'm not really sure if it was the result of their dyslipidemia and very high triglycerides that resulted in their liver enzymes going up, because people with fatty liver will have an increase in the liver enzymes. But what I observed that over a period of time, these liver enzymes eventually fell. So I think with long-term use, I don't really think that it's an adverse effect. Next question, is testosterone used as one of the ingredients in wound products? It's not, probably should be. I probably wouldn't use it on the wound itself, although you could. I would rather use it on the typical places that we use it in order to increase serum levels so that it's in a serum in the blood that will hopefully get through to the wound. The problem is that many wounds are avascular, and the blood can't get to them. And so if you measured oxygen content of the wound, the oxygen content of the wound is very, very low, which is why the use of hyperbaric oxygen to try to increase oxygenation of the tissue, and you can't because there's no blood flow going to it. So I haven't looked at using testosterone in the wound, but certainly something that I would probably consider doing in the future. Dr. Kern writes, hi David, can't correctly test testosterone levels too soon after applying the cream. Levels can be high. Yeah, sure. They can be too low if you wait too long. They can be too high if you test it right away. Again, the literature says you should test the levels, but none of the literature ever says when you should test the levels. Yeah, nobody's really looked at that. Everyone says, oh, you got to test it, but no one says, well, how do you interpret those levels? The level's high right afterwards, and the level's low if you wait a while. So the levels are completely nebulous. They're completely meaningless. You can manipulate when you test it to get a level that pleases you the most. You can manipulate the time in which you test it to get a level that pleases people the most or that does not upset people the most. So again, I don't usually look at levels per se to restrict therapy. I might look at a level and say, you know, look, your level was 300 and now it's 1800. Look how much it went up. Look at your cholesterol, look at your lipids, look how much they've improved. But I typically don't use a level to restrict therapy, and everyone wants to do that. Sometimes even the night before, yeah. If you get a number that bothers you, then don't test it. If you get a number that bothers you, retest it, but don't take the testosterone the night before. Or don't take the shot several days before. Wait until the testosterone level has fallen down significantly, and then test it. And it'll give you a number that's very low, and it will give you that number that says, okay, good, the level's low, I can then treat them. And what you've done is you've manipulated the time in which you test it to give you a number that pleases you the most, or pleases somebody else the most, but you cannot use that number to adjust the therapy. All you can do is use that number to document, well, see, the number's still low, so I'm still okay in giving it, and no one's going to criticize me for giving it because the level is low. Anyway, thanks for bringing that up, David. Best wishes to you, and hope to see you towards the latter part of the year. That's the last question I have. Hope it was fun. Hope to see you all at some upcoming courses or at Part 5 Beyond Hormones this October. Thank you very much. Back to you, Mary.
Thank you, Dr. Rouzier. I hope our listeners enjoyed it as much as I did. Our next webinar is scheduled on Friday, August the 18th, and will feature Dr. Teresa Ramsey discussing metformin and its other mechanisms of action in addition to insulin resistance. Thank you again, Dr. Rouzier, and everyone who joined us today. Have a wonderful rest of your day.